In this module, we'll review the latest biologic-based targeted therapies for asthma. Our discussion will differentiate between biologic agents, focusing on mechanism of action, as well as the latest safety and efficacy data of targeted therapy. Before considering biologic therapies, it's important to take a stepwise approach in the management of asthma. First of all, one needs to confirm a diagnosis of asthma and also assess inhaler technique and adherence. It's important to recognize that poor adherence to asthma medication accounts for 50 to 80% of uncontrolled asthma. Furthermore, one needs to assess coexisting conditions, risk factors, and triggers of asthma. Coexisting conditions include chronic rhinosinusitis, gastroesophageal reflux disease, obstructive sleep apnea, and other comorbidities, including vocal cord dysfunction. It's also important to recognize asthma triggers that can be avoided by the patient, particularly specific allergens that can be avoided and potentially be causing asthma to worsen. One can also review biomarkers of asthma activity, including eosinophils and exhaled nitric oxide, that can all be markers of adherence to inhaled corticosteroid therapy. The first-line therapy for patients with asthma is generally inhaled corticosteroids. These therapies have been long approved for persistent asthma, from mild disease to more severe disease. Inhaled corticosteroids are convenient, inexpensive, and safe drugs that have a broad mechanism of action. They affect eosinophils, lymphocytes, mast cells, and dendritic cells, and they're effective in a majority of asthmatics. They're less effective in more severe patients, however. In those cases, in patients who are poorly controlled despite using low doses of inhaled corticosteroids, one can increase the dose of inhaled corticosteroids or consider addition of other agents, including long-acting beta agonists, long-acting muscarinic agents, or leukotriene receptor antagonists. These therapies are often beneficial and add bronchodilation to the anti-inflammatory effects of inhaled steroids. They all help in terms of reducing exacerbations, improving lung function, and improving symptoms related to asthma. When considering inhaled corticosteroid add-on therapy, it's important to recognize that inhaled corticosteroids, particularly inhaled corticosteroids, but also oral corticosteroids, with or without other controller therapies, may offer only partial control of severe asthma. So for those patients who are on either inhaled corticosteroids monotherapy or combination therapies, one should consider first non-biologic add-ons and then consider treatment with biologic agents. The non-biologic add-ons to consider include long-acting beta agonists, which improve dilatation of the airways through activation of beta agonist receptors, tiotropium, which is a long-acting muscarinic agent. Macrolide antibiotics have been tested, not approved for asthma, but have been shown to improve outcomes in patients with asthma. Leukotriene modifiers, and bronchial thermoplasty. All of these therapies have been shown to improve outcomes in patients with asthma. If these therapies are tried, then afterwards, if they're not successful, one should assess for targeted treatments with biologic agents. And this may include workup with specific biomarkers. When treating patients with inhaled corticosteroids, the next approach in those who are poorly controlled is often to increase the inhaled corticosteroids. And in patients who are on combinations of therapy, many doctors still give oral corticosteroids, such as prednisone. However, with regard to inhaled corticosteroids, there's a limited dose response curve. And for oral corticosteroids, there are many side effects, and corticosteroids are often associated with systemic toxicity, including adrenal insufficiency, weight gain, hypertension, cataracts, glaucoma, and osteoporosis. So in those patients, it's really important to consider patients for more targeted therapies. However, to better understand novel asthma treatments, one needs to understand the underlying asthma pathophysiology. And our recent studies have demonstrated a significant improved understanding of the underlying pathophysiology of asthma, especially type 2 asthma and eosinophilic inflammation that have led to the latest targeted interventions. These targeted therapies have been shown to reduce the number of exacerbations of asthma, improve lung function, and improve asthma-related symptoms. Currently, we have 4 approved targeted therapies in asthma, including those therapies that target interleukin-5 and IgE, and one therapy that's in development that targets interleukin 4 and 13. So it's important to understand all of these type 2 cytokines, including IL-4, IL-5, and IL-13, as well as the role that IgE plays in the pathophysiology of asthma. Asthma can broadly be broken down into type 2 inflammation and non-type 2 inflammation. Type 2 inflammation is brought on by activation of both Th2 cells as well as innate lymphoid cells, or ILC2 cells. These cells bring about and produce type 2 cytokines, including IL-4, IL-5, and IL-13. IL-4 is involved in activation of B cells that produces IgE, and IgE binds to mast cells and causes mast cell degranulation and release of a variety of different mediators, including histamine. IL-5 is a pro-eosinophilic cytokine that regulates proliferation, maturation, migration, and effector function of eosinophils. IL-13 is a cytokine that's associated with eosinophil trafficking and production of nitric oxide from epithelial cells, as well as mucus production. And IL-4 is a cytokine that's found in increased levels in the airways and sputum of asthma patients and is involved in eosinophil trafficking and in B cell production of IgE. TSLP is a novel target. It's short for thymic stromal lymphopoietin, and it's an epithelial cell-derived cytokine that drives allergic inflammatory responses and drives type 2 inflammatory responses by activating dendritic cells and mast cells. In addition to type 2 pathways of inflammation that are generally brought on by allergens, there's also non-type 2 inflammatory pathways that are generally brought on by bacteria, fungus, viruses, and irritants, including smoking. Key to non-type 2 inflammation is IL-17. IL-17 is a cytokine that's produced by Th17 cells and plays an important role in immunologic responses seen in asthma. Also important in non-type 2 inflammation is interleukin 6, interleukin 8, and TNF-alpha, as well as CXCR2. That's a potent chemotactin for neutrophils, and that's currently under investigation in asthma and COPD. Other non-type 2 cytokines that are important include interleukin 33, which also plays a role in activation of both type 2 as well as non-type 2 inflammatory pathways. Currently, we have several biologics that are approved for management of asthma. These include agents that target interleukin 5, IgE, and therapies that are in development, including those therapies that target the IL-4 receptor that blocks both IL-4 and IL-13. Let's talk about each of these. Benralizumab is a monoclonal antibody that was approved for the management of eosinophilic asthma in November of 2017. It binds to the IL-5 receptor alpha and is an injectable therapy that's safe and well tolerated. The Sirocco and Kalima studies demonstrated that benralizumab offers significant benefits in terms of reduction in asthma exacerbations in patients with eosinophilic asthma who are poorly controlled on inhaled steroids and long-acting beta agonists. After being administered every 4 weeks for the first 3 doses, it can then be administered every 8 weeks thereafter and has been shown to be effective in that patient population. In a steroid-sparing study published by Param Nair and colleagues in the New England Journal of Medicine in 2017, benralizumab was shown to reduce asthma exacerbations by approximately 70% and reduce steroid dosing also by about 50% compared to placebo. Another monoclonal antibody that targets IL-5, not the IL-5 receptor, is reslizumab. Reslizumab was approved in April of 2016 for management of patients with eosinophilic asthma. It's an intravenous therapy that's dosed 3 milligrams per kilogram and has been shown to be effective both in terms of exacerbation reduction, but also in terms of improvement in lung function in patients with severe asthma. The greatest results were seen in patients who had blood eosinophil counts above 400. And it's been shown in several studies now to improve not just exacerbations, but also symptoms and asthma-related quality of life. And of course, it's also been shown to reduce the number of eosinophils in the blood as well as in the sputum. Mepolizumab is another monoclonal antibody that was the first monoclonal antibody that targeted interleukin-5. It's been shown to improve asthma exacerbations in patients with eosinophilic asthma, and has been shown to not only reduce exacerbations, but one study also demonstrated significant reduction in steroid dosing and in exacerbations in patients who were treated with oral corticosteroids. It's dosed on a monthly basis, subcutaneously, 100 milligrams each month. It's also been approved by the FDA at a higher dose, 300 milligrams, for another eosinophilic condition, eosinophilic granulomatosis with polyangiitis. Omalizumab was the first monoclonal antibody approved for the management of asthma, and it was approved in 2003 as an injectable, subcutaneously administered monoclonal antibody that targets IgE, immunoglobulin E. IgE generally binds to mast cells, and when it interacts with an allergen and cross-links with other IgEs, results in mast cell degranulation and release of different mediators, including leukotrienes and histamines. Early data demonstrated that omalizumab is very effective in patients with allergic asthma. It's also approved for patients with urticaria, and it's been shown to reduce asthma exacerbations on the order of about 50% in patients with the allergic asthma phenotype. However, recent studies by Nick Hanania and colleagues have also demonstrated that omalizumab is effective, particularly in patients with high eosinophils, high IgE, high periostin, and high nitric oxide levels, offering greater benefit than in patients who have lower levels of those biomarkers. The newest monoclonal antibody that's been in development is a monoclonal antibody that targets the interleukin-4 receptor alpha. The IL-4 receptor alpha binds to both IL-4, interleukin-4, as well as interleukin-13, two important cytokines important in both eosinophil trafficking, production of mucus, as well as production of nitric oxide. Dupilumab is currently under FDA review with a target action date of October 2018. It's been shown to be safe and well tolerated, and phase 3 studies as well as phase 2 studies have demonstrated broad efficacy with significant reduction in asthma exacerbations in patients with eosinophilic asthma, patients with high nitric oxide levels, and patients who are on or not on oral corticosteroids. The magnitude of benefit with dupilumab has been demonstrated with reduction in exacerbations, particularly in patients with high EOs and high ENO, but also it's been shown to be effective in patients who are on oral corticosteroids. In that patient population as well, as demonstrated by a publication by Klaus Rabi and colleagues, dupilumab has been shown to reduce exacerbations as well as improve lung function and allow or facilitate corticosteroid withdrawal. One of the challenges that clinicians currently face is deciding between different biologic agents. And one of the problems is that there are no head-to-head studies comparing one biologic to another. However, in 2017, there was a Cochrane review that evaluated 13 studies that included 6,000 patients who received different biologic therapies. This Cochrane review compared agents targeting the IL-5 or IL-5 receptor against placebo and evaluated mepolizumab, reslizumab, and benralizumab. The Cochrane review showed that all IL-5 therapies reduced rates of clinically significant asthma exacerbations by about 50% in patients who had severe eosinophilic asthma, and supported the use of anti-IL-5 therapies as an adjunct to standard of care in people with severe eosinophilic asthma and poor control. It's important to recognize, however, that there was limited evidence for improved healthcare-related quality of life as scores as well as lung function. Another therapy that's important to consider for patients with severe asthma is bronchial thermoplasty. Bronchial thermoplasty is a procedure that involves delivering heat to the airways of patients with severe asthma. This is done bronchoscopically with a catheter that's deployed through a bronchoscope into the airways. At one end of the catheter, there is a basket that heats up, and at the other end of the catheter is hooked up to a heat source that delivers thermal energy up to 65 degrees Celsius. Bronchial thermoplasty has been approved by the FDA in 2011 and has demonstrated to reduce asthma exacerbations, and 5-year long-term studies have shown sustained reduction in exacerbations, emergency room visits, and hospitalizations, and it's been shown to be a safe therapy with no evidence of any long-term reduction in lung function, no evidence of bronchiectasis. Recently, some real-world studies have demonstrated sustained efficacy out to 3 years in a non-clinical trial situation in patients who receive this procedure. This is another viable option for patients with severe asthma. In conclusion, asthma therapy has evolved a long way from just use of inhalers in patients with moderate to severe asthma. We now have more targeted therapies that target specific pathways. We've recognized the importance of evaluating for endotypes of asthma, the specific mechanisms of asthma in a given individual, to identify whether a patient has type 2 inflammation or non-type 2 inflammation, eosinophilic asthma or non-eosinophilic asthma, IgE-mediated asthma or non-IgE-mediated asthma. And identifying these specific targets allows us, by using biomarkers, to identify appropriate therapies that are novel, targeted for the patient, so that we can identify the right drug for the right patient at the right time based on the science of the disease. This is an exciting time for the management of asthma, as we have new therapies now, and it's exciting because we will soon be developing other new therapies that are on the horizon.